Hello everyone and welcome to our next session of cardiovascular pharmacology and clinical pharmacology. Today we are going to cover a very important section and topic in clinical pharmacology. So as you can see here in the slide, so as you can see here in the slide here, the topic will be covered in the cardiovascular clinical pharmacology. We have diuretics, we have antihypertensive drugs, angina, cardiac arrhythmias, antihyperlipidemic, and heart failure. 6 main topics and considered like one unit, and we have 6 chapters. And the most important part, all these topics is very important, but diuretic involve in, for example, in treatment of hypertension, diuretic involve in treatment of heart failure and other disease also. So it's very important to focus on the first topic in order to be applied for the other topics in pharmacology. So we are going to start speaking about diuretic first, and this will take time, and we need to practice in order to understand the concept of diuretic. So as you all know that diuretic, we are talking about the medication or drugs that affect the kidneys. And we know that the kidney may be involved in several diseases, and one of the most important disease I tried to define that disease that involved with the kidney function, with the disease associated with edema and disease associated without edema. So we have a disease considered like edematous states. This is the kind of disease associated with edema. For example, heart failure associated with edema. We have hepatic ascites associated with edema, nephrotic syndrome, and heart failure. So this is the most popular maybe diseases associated with edema: heart failure, hepatic ascites, nephrotic syndrome, and renal failure. Okay, for speaking about non-edematous states, the kidney plays an important role with that. Hypertension. Here, what we have, we don't have edema, but we have disease, and the kidney involved in this disease play significant role in this disease. Number 1, hypertension. Number 2, hyperkalemia. Number 3, nephrolithiasis. And number 4, diabetes insipidus. Nephrolithiasis, here we talk about the kidney stone, or like elevated level of oxalate or uric acid, or anything may predispose to the kidney stone. So we have 2 cases here. We have edematous disease associated with edema and the kidney involved in this disease: heart failure, hepatic ascites, nephrotic syndrome, and renal failure. Non-edematous disease, we have hypertension, hyperkalemia, nephrolithiasis, diabetes insipidus. So we are going to speak about the application of diuretic for this disease. Okay. Start talking about diuretic and the definition for diuretic. We all now know that is about 16 to 20% of blood filtered in the Bowman capsule in the kidney, and the filtration include so many material there is important for our human and cells. What we have here, we have a glucose, sodium bicarbonate, amino acid, electrolyte. So the filtration, the urine include glucose, the urine includes sodium bicarbonate, the urine include amino acid, and electrolyte including sodium potassium chloride. But you can look what we have here. We have amino acid. The amino acid is an important part for synthesis of protein. So we need amino acid. We don't need amino acid to be on the urine. Therefore, in the kidneys, what happened there? We have system called passive reabsorption. So amino acid will be reabsorbed again from the urine. Amino acid will come back again from the urine to the blood. Okay, so this is how this mechanism works. Glucose will be returned again from the urine to the blood. bicarbonate from the urine to the blood. So the kidney tried to reabsorb the important nutrient and bring these nutrient to the blood. Okay. What we have, if you look on the nephron, the nephron, this is the major unit of the kidneys. The nephrons, we have 5 zones in the nephron, and these zones responsible for regulate urine ionic compositions by 2 mechanisms: active reabsorption or active secretion. Here we are talking about ATP, and against concentration gradients, and we have passive reabsorption. So we have 2 mechanisms involved in regulating fluid and electrolyte movement in the kidneys. Number 1, active reabsorption, or we call this one secretion, active secretion, and we have passive reabsorption of water. Okay, so regarding when we finish this lecture or this video, the audience or the people who attend this lectures will be familiar with this group of medication. We can add another group, but for example, thiazide, loop diuretic, potassium-sparing diuretic, and carbonic anhydrase, osmotic diuretic, and we can add another group, ADH or vasopressin. So we have how many groups? We have 6 groups. This is 1, 2, 3, 4, 5, and ADH considered like number 6. So we have 6 group of medication affect the nephron, and you already familiar now. We are talking about, we have zones in the nephron, and if you go to the previous slide, we are talking about 5 nephron zones. Okay, so what we have here, as you can see, if we talk about thiazide, we have group of medication include for the diuretic thiazide, we have hydrochlorothiazide, chlorothiazide, chlorthalidone, and dipamide metalazone. For the loop diuretic, we have furosemide, Lasix, bumetanide, ethacrenic acid, and torsemide. Okay, moving to the next slide. So for this one here, in this group, as you can see, what we have 2 groups of medication in the slide, thiazide and loop diuretic. For thiazide, we have hydrochlorothiazide, chlorthalidone, chlorothiazide, and dipamide, metalazone. Loop diuretic, we have furosemide, Lasix, the brand name. Then we have bumetanide, ethacrenic acid, and torsemide. Okay, moving to the next group of medication here, we can see here we have potassium-sparing diuretic, we have amiloride, eprinone, spironolactone, and we have now a new medications in this group. If you talk about the aldosterone antagonist, we have another medication, new medication, approved and available in the market since 2021. We are going to speak about that later on under the topic of potassium-sparing diuretic. So amiloride, triamethrin, eprinone, spironolactone. This is considered like potassium-sparing diuretic. Okay, moving to the group 3, we have carbonic anhydrase inhibitor. We have acetazolamide, dorzolamide, brinzolamide. For the osmotic diuretic, also we have mannitol, we have glycerin, and we have urea. We can type here urea, and another medication. So we have 4 medication with osmotic, but the most popular one, as you can see, mannitol and glycerin. Okay, the classification of, speaking about classification of diuretic, okay, how we classify the diuretic here. First, we need to look on the nephron. And this is hand maybe written nephron and hand maybe painting nephron. You can see here we have glomerulus Bowman capsule. Then we have proximal convoluted tubule. We have BCT, proximal convoluted tubule. Then we have TAL, stand for thick ascending loop of Henle. Okay, then we have distal convoluted tubules, DCT, and collecting duct or conducting collecting duct, and collecting tubule. So we have, as you can see here, we have 5 parts in the nephron. First part, BCT, proximal convoluted tubule. The second part, descending loop of Henle. The third one, thick ascending loop of Henle. Next, we have distal convoluted tubule. Then we have collecting duct and collecting tubule. So we need you to remember these main parts in the nephron, because this nephron represents the site of action of diuretic. Okay, moving to the looking maybe further to in details what happened in the nephron, we can maybe look on the details for the BCT, for the proximal convoluted tubule. Number one, this part of nephron responsible for reabsorption of sodium bicarbonate. So we need to remember that. So the question now, which part responsible for sodium bicarbonate? So proximal convoluted tubule. And they found this part responsible for the absorption of 65 to 70% of sodium in this nephron, proximal convoluted tubule. The second part will be descending loop of Henle, and this responsible for reabsorption of water. So bring the water from the nephron to the blood. So we have urine here inside. We have the urine. Outside we have the blood. So you can see here the nephron bring the water from the nephron to the blood through the descending loop of Henle. Moving to the ascending loop of Henle, thick ascending loop of Henle, what we have here, you can see we have a transporter, and you can see the transporter here. I will maybe use the mouse here. You can see the transporter, and this transporter, they said I can draw maybe another line here like this one. I will draw, make it available here. This transporter in the thick ascending loop of Henle responsible for reabsorption of sodium, chloride, potassium. And we can type here 2 chloride, sodium, chloride, potassium, 2 chloride. So reabsorption from the urine to the blood. So this will be our target. So in the thick ascending loop of Henle, we have co-transporter. This is co-transporter here. And this co-transporter is responsible for reabsorption of sodium, 2 chloride, potassium from the urine to the blood. And this may be responsible for reabsorption of sodium. 25% of sodium will be reabsorbed through this mechanism. Okay, moving to the distal convoluted tubule, this is responsible for 5% of sodium absorption. And what we have there, we have sodium co-transporter in the DCT. Okay. So we need everyone to remember what type of transporter or exchanger available in the nephron. So in the distal convoluted tubule, we have here, as you can see on the screen, we have a co-transporter for sodium chloride, and this is responsible for 5% of sodium reabsorption. Okay, so we have sodium chloride, and this is available in the distal convoluted tubule. Okay, moving to the last part of the nephron, we're going to speak about collecting tubule and collecting duct. Okay, for the collecting tubule and collecting duct, we have sodium, potassium, hydrogen exchanger, sodium, potassium, hydrogen exchanger, and this is responsible for 1 to 2% of the moving sodium outside from the urine to the blood. So drink the sodium from the urine to the blood. Okay. Site of action here. So we are going to, so what we have here now, we are familiar with the part name of the nephron. We have Bowman capsule, proximal convoluted tubule, thick ascending loop of Henle, distal convoluted tubule, collecting duct. Then we discuss what type of transporter or exchanger. So we have transporter and we have exchanger and then nephron. Okay. Now we try to figure out the site of action for the group of medication. We have group of medication affect the nephron and used as diuretic. So diuretic classification, we talk about loop diuretic. From the name, when you say loop diuretic, what do you think the site of action here when you say loop diuretic? So if you said number 3, so we can see number 3 here, loop diuretic, thick ascending loop of Henle. So I will type here number 3. Okay, what about thiazide diuretic? Thiazide diuretic work on the DCT, okay, thiazide diuretic, and distal convoluted tubule. Number 4. Potassium-sparing diuretic. So which one affect potassium? Collecting duct. And the number for this part here, number 5. Carbonic anhydrase inhibitor. This enzyme, carbonic anhydrase, the abbreviation for this one, this enzyme here, Ca. And this is responsible for formation of bicarbonate, sodium bicarbonate. So the ideal place or site of action will be number 1. Okay, what about osmotic? Osmotic bring the water from the urine to the blood. Should be BCT, proximal convoluted tubules, and number 2, descending loop of Henle. So now in this case, we need you to be familiar with the site of action of diuretic. So next slide show you the answer and according to the order 1, 2, 3, 4, and 5. For example, part 1 with the DCT, part 1 we have carbonic anhydrase inhibitor, part 1. Okay, part 1 and 2 we have osmotic. Part 1 and 2 we have osmotic diuretic. Loop diuretic, number 3. What about number 4? Thiazide. What about potassium? Number 5. So we are putting here everything. So what we have here, we have number 1, for example, if you click on the okay, this one here should be carbonic anhydrase inhibitor. Then number 2 here we have, this is number 2, 1 and 2. This one we talk about osmotic. Okay, number 3 loop diuretic, number 4 thiazide, and number 5 we talk about potassium sparing diuretic. Okay, so we need the student and the audience to be familiar with the site of action. So we need you to be familiar with this one, the site of action of diuretic. Okay, nephron and blood pressure, absorption of water and sodium will increase blood pressure. So when you have urine, and in the urine we have sodium and water, and this will be reabsorbed to the blood. Okay, the result will be increased blood pressure because we have sodium. Okay, diuretic. Now when you prescribe diuretic, prevent absorption of water and sodium, prevent absorption. Okay, what happened when you prevent absorption? The blood pressure will be decreased. So the purpose of using diuretic in patients with hypertension to decrease blood pressure. The popular medication used for hypertension from this group, thiazide, most popular medication. Okay, thiazide, the most popular medication used for hypertension. Okay, start with the first group of medication for diuretic. You are familiar with this one, proximal convoluted tubule. We have a group of medication called carbonic anhydrase inhibitor, CAIs, carbonic anhydrase inhibitor. We have acetazolamide, dorzolamide, brinzolamide. Site of action, proximal convoluted tubule. So the question now, where is the site of action or of carbonic anhydrase inhibitor in the nephron? The answer will be proximal convoluted tubule. Give me a name of medication belong to the carbonic anhydrase inhibitor. We have acetazolamide, dorzolamide, brinzolamide. Okay, moving to, so from this, maybe in this slides we are going to learn about the site of action, a group of medication, and drug belong to the H group. So I will repeat: proximal convoluted tubules, the site of action for carbonic anhydrase. Medication belong to the carbonic anhydrase inhibitor. We have acetazolamide, dorzolamide, brinzolamide. Okay, next we have osmotic diuretic, and the site of action will be proximal convoluted tubules and descending loop of Henle. So two places, as you can see here, two places, proximal convoluted tubules and descending loop of Henle. Examples, we have mannitol and urea. This medication prescribed IV. Okay, this medication prescribed IV. I will maybe minimize this one just in case we need to see the entire slide. Okay, so you can see here we have mannitol and we have glycerin. So mannitol and glycerin, mannitol and urea prescribed IV, glycerin isosorbide prescribed orally. So this is another group of medication. Okay, this is the second group. Okay, the question here, where is the site of action of osmotic diuretic? So we can speak about proximal convoluted tubules and descending loop of Henle. Give me an example for medication belong to the osmotic diuretic: mannitol and urea, glycerin and isosorbide. Which of these osmotic diuretic given IV? Which of these osmotic diuretic given orally? So we have mannitol, urea, IV, glycerin, isosorbide orally. Okay, moving to the next group of medication, group number 3. So we discussed number 1, carbonic anhydrase. Number 2, we discussed the osmotic. Number 3, we have loop diuretic, as you can see it here. The site of action, thick ascending loop of Henle. The site of action, thick ascending loop of Henle. So number 3, as on the nephron. Give me an example: furosemide, Lasix, bumetanide, ethacrenic acid, torsemide. So we have 4 medications belong to the loop diuretic: furosemide, bumetanide, ethacrenic acid, torsemide. The question now, where is the site of action of loop diuretic? Thick ascending loop of Henle. Give me an example for medication belong to the loop diuretic. Yes, we have furosemide, bumetanide, ethacrenic acid, torsemide. Okay, so this is group 3. Okay, group number 4. We are talking about the distal convoluted tubule. We have a group of medication called thiazide. Okay, thiazide. Okay, thiazide. The site of action, proximal convoluted tubule, as you can see it here. Example, we have chlorothiazide. Then we have hydrochlorothiazide, chlorthalidone, and dibamide metalazone. So we have several medications belong to the thiazide. I will repeat: thiazide is a group of medication work on the distal convoluted tubule. Okay, example of this medication: hydrochlorothiazide, chlorthalidone, chlorthalidone, hagritone, and dibamide. Then we have metalazone. This is group number 5. Okay, group number 4. Group number 4 include potassium-sparing diuretic, and we have vasopressin or ADH. ADH, and we need to maybe add something here. We can say ADH antagonist. Okay, so we have potassium-sparing diuretic and ADH vasopressin antagonist. The site of action will be collecting duct, collecting tubule. So we have two group of medication, potassium-sparing diuretic. Then we have ADH vasopressin. For potassium-sparing diuretic, we need you to remember this list of the medications: amiloride, triametrin, eprinone, spironolactone, aldactone. So this belongs to the potassium-sparing diuretic. The list of ADH antagonists, we have it later on, but we need you to remember the site of action for this two group of diuretic, potassium-sparing diuretic and ADH vasopressin on the collecting duct and collecting tubules. But if you look at what we have here for ADH vasopressin, this hormones, ADH vasopressin, this is hormone, not diuretic. This one should belong to the hormone pharmacology or endocrine pharmacology. Therefore, we are not going to discuss it in details in our lecture or in our video today. And we are going to cover this topic for ADH and the endocrine pharmacology. So the question now, where is the site of action of potassium-sparing diuretic, collecting tubule and collecting duct? Give me an example for medication belong to the potassium-sparing diuretic. We have four names: amiloride, triametrin, spironolactone, eprinone. So four medication belong to the potassium-sparing diuretic. Okay, we done with the diuretic. We discussed the medication name. We looked on the Nephron. Okay, so as you can see here, we have a group of medication, category, classification. We have osmotic. Then we have carbonic anhydrase, loop diuretic, thiazide, potassium-sparing, and vasopressin antagonist. We discussed in the previous slides, we discussed the site of action of these medications, where the location, site, and then we go from there. So the next part, we're going to speak about the mechanism of action, how this medication work, what is the consequences, what happened if this medication prescribed to the patient. So we already covered the site of action, as we discussed that, and then Nephron. We discussed the site of action. Okay, we discussed the site of action with you. But in the next slides, in the next coming slide, we are going to speak about the details, mechanism of action, actions, therapeutic uses, side effect, and contraindication. Okay, let us continue our lecture about diuretic. As you already aware, we already covered the kidney. We talked about the nephron parts, and we already explained the different function of the nephron, speaking about proximal convoluted tubules, descending loop of Henle, ascending loop of Henle, and then we have thick loop of Henle, we have distal convoluted tubules, and then we have collecting tubule and collecting duct. We explained the function of the transporter and exchanger in each part of the nephron. Then we tried to place a site of action of these medication, group of medication: osmotic, carbonic, loop, thiazide, potassium-sparing diuretic, and vasopressin antagonist. Next part, we are going to speak about the mechanism of action. What is the consequences when you prescribe this medication to your patient? What happened to the nephron? What type of exchange maybe reflect on the nephron regarding elimination of water and sodium, potassium, and other electrolyte? So as you can see here, we have six major group. The number 6 will belong to the hormones more than a diuretic. Maybe will be covered in details in the hormone or endocrine pharmacology. The major group: osmotic, diuretic, carbonic anhydrase, loop diuretic, thiazide, potassium diuretic, potassium-sparing diuretic, and ended up with the vasopressin diuretic. Okay. As you can see here, we're talking about thiazide, loop diuretic. We have group of medication here. We should be covered. Okay. Let us start with the first group of medication. Okay, first group of medication, we have osmotic diuretic, and the main medication in this group, mannitol, but we have four medication in this group. We have mannitol, we have urea, we have glycerin, we have isosorbate. Mannitol is a filter through the glomerulus, through the Bowman capsule, prevent reabsorption of water. Okay, the site of action, BCT, this is the main site of action, and also affect descending loop of Henle. So the question, where is the site of action of osmotic diuretic, will be proximal convoluted tubule number 1, and number 2 will be descending loop of Henle. Okay. This mannitol prescribed IV, and if you give it orally, this medication will not be absorbed. This is very important concept here. Okay, the site of action again, major site of action will be BCT, convoluted proximal convoluted tubules, and will be secondary affect the descending loop of Henle. Okay, talking about the mechanism of action. Before we go there, we need you to remember we have 4 group of medication in this list. We have mannitol urea, this prescribed IV, intravenous. Then we have glycerin isosorbate dinitrate. This is given orally. How this medication work? Okay, before we go to the apply the medication, we need to remember what happened in these cells and in the nephron, in this part of the nephron. This one here, in the middle represent the cells. Here we have the urine, lumen, then we have the blood. So we have three main parts: the lumen, the cells, the blood. The function of these cells here to reabsorb the water from the lumen to the blood, crossing the cells, reabsorbed, crossing the cells, and arriving to the blood. So we need water in our blood. When the water arrives to the urine, the nephron will be reabsorbed water and bring it back to the blood. Okay, what happened there? Okay, so what happened when you prescribe mannitol to your patient? This is the mannitol here. The mannitol will arrive to the lumen, to the urine, and the mannitol will stay in the urine like sponge. Will stay in the urine and try to absorb the water, try to suck with water, carry a lot of water, and when the mannitol prevent reabsorption of water, that means prevent absorption of water from the lumen, urine, through the cells arriving to the blood. This crossing will be inhibited. So mannitol inhibit or limit reabsorption of water. This is very important. Decrease reabsorption of water in the tubules. Okay, what happened here? We have, in this case, we're going to have a lot of water in the urine. So we can make it like arrow. A lot of water in the urine. And what happened to the blood? We have less water in the blood. So the limit reabsorption of water in the tubules. That's great. And what happened? The patient will start maybe go to the bathroom frequently to empty the bladder, because we have increased excretion of water here. Okay, so what we have here, we have urgency of your urination, and the osmolarity of the urine will be increased. Okay, because we have delusional state. Okay. So mannitol limit decrease reabsorption of water in the proximal convoluted tubule mainly, and secondary in the descending loop of Henle. Mannitol, as you can see, prevent limit reabsorption of water from the urine to the blood. Okay, mannitol clinical use. So here where patient will start enhance urination, increase urination. They said this group of medication, especially mannitol, used for patients suffer from cerebral edema by decreasing intracranial pressure. Number 1. This medication used to reduce intraocular pressure. Intraocular pressure. Intra mean inside. Ocular stand for the eye. So intraocular pressure. Here we are speaking about glaucoma. So this medication could be used for treatment of glaucoma. Number 1, cerebral edema. Number 2, glaucoma, reduce intraocular pressure. Number 3, this medication used to maintain a urine flow following acute toxic ingestion of substances that produce acute renal failure. So this medication enhanced diuresis. And in patient with acute renal failure, the patient will not be able to, the kidney in the patient will not be able to function. The kidney will stop function. So our medication here, osmotic mannitol, enforces the kidney to start, maybe remain functioning by elimination a lot of water. So this is very important here. So maintain urine flow. So our medication, the purpose of mannitol during acute renal failure, to maintain urine flow following acute toxic ingestion substances. Side effect. You can imagine now the patient losing a lot of water. Main side effect will be dehydration because they're losing a lot of copious amount of water. Okay, so what happened next? If we lose a lot of water here, you can imagine now we have a container, and in this container we have water here. Okay, but at the same time, and we are talking about the urine, at the same time we have sodium. So in this urine we have sodium and water. Okay, that's great. Now we move to the next one. Maybe we need to explain it a little bit in the... Okay. Okay, so the first one here, we can maybe, if you have the first container here, and we have the urine. This is the urine. Okay, then we have electrolytes. Could be sodium, could be potassium, could be magnesium in the urine. All these like particles of sodium, let me say. And then we have water, and this is represent maybe the lumen of the nephron. So the mannitol increase excretion of water, prevent reabsorption. So what happened for this container? So what happened? The level of water will be decreased. You agree with this one? So we don't have enough water. We have decreased water, kind of dehydration. Okay, decreased level of water. Okay. Again, what happened there? We still have the same level of. We have the same concentration of particles or of sodium. Okay, we still have a lot of sodium in the cells and blood. The situation here, do you agree this will associated with the decreased water and increased level of sodium, increased concentration of sodium? Okay, I will go back again. When we have an increased extracellular water due to the osmotic effect in the systemic circulation, the situation will be hyponatremia. Okay, well, the situation will be hyponatremia. This one needs to be explained. So what we have here, we have an increased extracellular water due to the osmotic effect and the systemic circulation. Okay, so back again, because we need to understand what happened. This one, This one happening in the urine. So this one in the urine. Okay, what happened on the between the cells and extracellular cells? Okay, this is inside the cell. This is extracellular cells. This is the blood. So our medication tried to bring the water from the cells. Okay, so our medication, mannitol or mannitol, bring the water from the cells to the extracellular cells, then to the blood to arrive to the urine. Okay, tried to bring. So what happened for the extracellular here? We have in the extracellular space we have a lot of water here in this process. When we try to bring water from the cells, we are going to have a lot of water in extracellular space. Extracellular space, we talk about blood. Here we have a lot of water in this process, a lot of water here. Okay, what happened to the sodium concentration when you have a lot of water? Do you agree with the decreased level of sodium? We call this one hyponatremia. Okay. Okay, this explains the expanding in the extracellular water, and the patient will suffer from hyponatremia due to the expanding extracellular water. Okay. So osmotic diuretic, we already talked about osmotic diuretic uses, clinical use is very important. We have mannitol, glycerin, urea, isosorbate dinitrate. How this medication work? Mannitol arrive to the urine when you prescribe it IV. Cross Bowman capsule arrive to the urine lumen in the BCT in the descending loop of Henle. Stay there, limit reabsorption of water in the tubules, and this will lead to the increased water excretion, increased amount of water excretion in urine, and we can use this one to remove water from inside the cells. So inside, when you have a lot of water in the cells, this medication remove water from the cells. So some medication need to remove water from the cells. Patients suffer from cerebral edema. So we have edema in the brain cells. This medication remove water from the cells. So for this reason, we can prescribe mannitol for patients suffer from cerebral edema. Number 2, this medication reduce intraocular pressure. Okay, for this reason, this medication could be used for glaucoma. This medication maintain urine flow following acute toxicity. Therefore, we can prescribe it during the acute renal failure. Mannitol adverse effect because mannitol increase excretion of water in urine. The patient may suffer from dehydration. We already discussed how this medication work on the level of extracellular fluid or level. What we are going to have expand. We are going to have increased water in the extracellular space, and the patient will suffer from hyponatremia. Okay. So we're done with the first part, osmotic diuretic. Moving to the second part, very important group of medication in diuretic, loop diuretic, very important. We have Lasix, furosemide, bumetanide, ethacrinic acid, torsemide. 4 medication in this group. So we need you to focus on this group. Again, I would like you to focus on this group 4 medications. What we have here, we have furosemide, Lasix, bumetanide, ethacrinic acid, torsemide. This is the most important medication. Okay, and we can type here, this is the most potent diuretic. Okay, the most potent diuretic will be loop diuretic. This medication work on mainly on the kidneys. Okay, so the second group will discuss the diuretic, loop diuretic. The site of action, as you can see for loop diuretic, the site of action will be thick ascending loop of Henle. Thick ascending loop of Henle. The site of action for loop diuretic, we have it here. And you remember here we have co-transporter. This is co-transporter, you can see it. The co-transporter called sodium, potassium, 2-chloride. So the co-transporter, sodium, potassium, 2-chloride. Okay, this group of medication, we already maybe covered the name, and we need you to remember the name: furosemide, bumetanide, ethacrenic acid, torsemide. Okay, this medication inhibit the co-transporter called sodium, potassium, 2-chloride. Okay, inhibit the co-transporter sodium, potassium, we have it here. So repeat the question. Which of the following medication inhibits sodium, potassium, 2-chloride and the loop of Henle? The answer will be loop diuretic. If you go back here to the slide, give me a medication that inhibits sodium, potassium, 2-chloride and the loop of Henle. So you can choose furosemide, you can choose bumetanide, or ethacrenic acid, torsemide. Could be group, could be medication name. Okay, how this medication work? As you can see here, this medication considered like the most potent, strong diuretic. I will type it here. This medication considered like strong diuretic, strong diuretic, and most potent. Please remember this one. Okay, inhibit the, you can see the inhibit sign, inhibit reabsorption of sodium, potassium, 2-chloride. That mean, and this is a urine here, and this is a blood. That when you inhibit this co-transporter, the result will be increased excretion of these ions in the urine. Increased excretion of these ions in the urine. What we have here, this medication, this loop diuretic, furosemide, will increase excretion of these ions in the urine. Okay, which ions? Sodium. Okay, then we have potassium, chloride, magnesium, and calcium. That's great. So this group of medication, this group of ions will be eliminated, or will be excreted through the urine, eliminated through the urine. This one will be in the urine, rich in the urine. The patient will eliminate these ions in the urine. So sodium, potassium, chloride, magnesium, and calcium will be enhanced in the urine. Okay, a group of medication. This medication prescribed orally. Increase urine flow. I agree with that. Increase urine flow because sodium pull out the water with it. So we have a lot of water with the sodium. Increase urine flow because water follow the sodium. Increase the sodium, chloride, potassium, water, calcium, magnesium excretion. And this group of medication considered like strong diuretic. Okay, question. Which of the following diuretic considered like strong diuretic? Loop thiazide. Okay, what happened there? They said this medication decrease blood volume. Okay, and this will lead to the decreased blood pressure. I hope this makes sense for you. Decreased blood volume, this will lead to the decreased blood pressure. Okay, so when you have loop diuretic prescribed to your patient will maybe increase excretion of water and sodium in the urine. Okay, that will lead to the decreased blood volume. Okay. Okay, the result will be, okay, decrease cardiac output. And we know from the equation, blood pressure equal to the cardiac output multiplied by peripheral vascular resistance. I would like to refer you to the hypertension lecture, maybe to understand the compensatory mechanism. So what we have here, this is the equation, the effect of diuretic, make it small, the effect of diuretic increase excretion of water and sodium, decrease blood volume, okay, and the result will be cardiac output will be decreased. So if the cardiac output decreased, okay, what happened to the blood pressure? Decreased blood pressure. So this is one mechanism, one important mechanism. Maybe someone will argue with us, okay, what about sodium? The same. Decreasing sodium will decrease blood pressure. So we have two main mechanisms, decrease blood volume, decrease absorption of sodium. Okay. Okay. So this is how this medication works. The question here, where is the site of loop diuretic? Site of action will be thick ascending loop of Henle. How this medication works? This medication works by inhibit the sodium chloride transporter, sodium potassium 2 chloride transporter, inhibit reabsorption of calcium and magnesium. This will lead to the decrease. This will lead to the decreased level of these ions in the blood. This one will be increased in the urine, but if you're speaking about the blood, what happened to these ions in the blood will be decreased. Okay, so you can imagine we have less sodium in the blood, we have less potassium in the blood, less chloride, less magnesium, less calcium. We have to stop here a little bit to think, okay, this medication increase excretion of calcium in the urine. We don't have enough calcium in the blood. This could be reflect on the, for example, what about bones, for example? We are going to have less calcium in the bone because we have relationship between the blood and calcium. Okay, the question here, we don't recommend to prescribe this medication for patients suffer from osteoporosis. Okay, because this medication causes hypocalcemia, decrease calcium in the blood. Okay, the loop diuretic, as we discussed, we have a group of medication. We have four. We have furosemide, prototype, brand name Lasix. We have bumetanide, torsemide. These three medication belong to the sulfonamide derivative. So we have four medication. The first three, bumetanide, furosemide, torsemide, derived from the sulfonamide. Ethacrenic acid, not sulfonamide. So this maybe in general we have four medication: bumetanide, furosemide, torsemide, ethacrenic acid. Which of these considered like sulfonamide? Loop diuretic sulfonamide derivative, we have three: bumetanide, furosemide, torsemide. Which of the loop diuretic medication considered not sulfonamide? We have ethacrenic acid. Okay. Which of these medication considered like more potent than furosemide, bumetanide, the most potent? Okay, so in general, loop diuretic considered most potent. Which of the loop diuretic considered the most potent? Bumetanide. Okay, most commonly used furosemide, Lasix. Most commonly used drug in the practice. So we have a lot of most here. Most commonly used drug for loop diuretic, thiazide. More potent medication than furosemide, bumetanide. Okay, site of action, thick ascending loop of Henle. Mechanism of action, we already discussed, inhibits sodium potassium 2 chloride transporter. Okay. This medication considered high efficacy in mobilizing sodium chloride from the body and reduce copious amount of urine. A lot of amount of urine. The patient will lose a lot of water in urine. Okay. What about ethacrenic acid? Ethacrenic acid, its use is limited, restricted, because it's associated with the adverse effect. This is number one. We are going to speak about adverse effect. And we have steeper dose curve. Steeper dose curve. Okay, when you prescribe medications, okay, the medication effect will be like this one. So increase or the effect will appear gradually on the patient. This is a normal medication. When we prescribe furosemide, bumetanide, the gradual appearance for the medication. Okay, but what they found here, when you prescribe ethacrenic acid, the urine production effect will be like this one. So this steep dose response, when you prescribe it, you see the fast effect, then drop suddenly. So we have steeper dose response curve. So we don't have like gradual effect. And this is considered like negative point for the ethacrenic acid. So two things: adverse effect, a steeper dose response. For this reason, ethacrenic acid is considered like last choice. We have bumetanide, furosemide. Bumetanide will be the last choice for us. Loop diuretic, when you prescribe it, this medication acts promptly, maybe a few minutes to maybe 20 minutes, 30 minutes. It depends on the route of administration. This medication work even if in patient with a poor renal function. Okay, this medication work on patient who have not responded to the thiazide. Let me say, for example, the patient suffer from a disease, and you prescribe thiazide to your patient, but there is no response. The patient does not respond to the thiazide, so the alternative will be furosemide, because like considered like most effective or most potent diuretic, even in patient with a poor renal function. Okay, it's very important here. Okay, increase with the loop diuretic. When you prescribe loop diuretic, the patient will lose calcium in the urine. So increase calcium content in urine. So the urine will be rich with the calcium. Okay, they said on the other hand, thiazide decrease calcium in the urine, decrease calcium concentration in the urine. Now we have two group of medication regarding potassium concentration in the blood. So you can see here what we have. They said they talk about calcium. We have loop diuretic, calcium. Here we are talking about urine. Okay, loop diuretic. Here we have thiazide. So what is the effect of loop diuretic on the calcium concentration in urine? Here they said for the calcium in urine, loop diuretic increase excretion of calcium in urine. Okay. On the other hand, thiazide, no, increase excretion in urine. The other hand here, okay, the thiazide decrease excretion of calcium in urine. So prevent calcium excretion. That means the calcium will remain in the blood. Remain in blood. Here, what happened to the blood here? Blood calcium. If you talk about calcium in the blood. Okay, let me change the color to make it more sense. For the blood, remain in the blood. Increase calcium in the blood. Here, talk about the blood. Okay, decrease calcium in the blood. So loop decrease calcium concentration in the blood. What about thiazide? Increase calcium concentration. Okay, that's good. So this is the effect. We have two groups of medication, two type of diuretic. Loop diuretic increase excretion of calcium. Okay, thiazide prevent elimination of calcium. Another maybe effect they found, loop diuretic increase prostaglandin synthesis, and this will lead to the decreased renal fiscal resistance and increase renal blood flow. This is a very important mechanism. May explain the effect on the blood pressure also. So this is another effect. Loop diuretic increase prostaglandin synthesis, decrease renal fiscal resistance, increase renal blood flow, and this may explain why, for example, loop diuretic and thiazide decrease blood pressure. So we have maybe several mechanisms. Number one, decrease blood volume. Number two, enhance elimination of sodium. Number three, increase renal blood flow through the prostaglandin synthesis. Okay. I will maybe summarize what happened there with the diuretic. And speaking about loop diuretic, okay, decrease blood volume. Number two, increase excretion of sodium. We talk about urine here again. Number three, increase synthesis of prostaglandin. So according to these three mechanisms, so decrease blood volume, this will decrease cardiac output, and for this reason will decrease blood pressure. That's great. Okay, decrease sodium in the urine, increase sodium concentration in urine. This will lead to the decreased sodium in the blood. Also may participate in the decreasing blood pressure. Increase prostaglandin synthesis and the what happened there. This will on the kidney level. This will lead to the renal blood flow. What that mean with renal blood flow? Here we talk about enhance renal blood flow, and this will maybe participate in the maybe maintaining blood pressure. Okay, so this is so many mechanisms, three mechanisms for loop diuretic to be involved in regulating blood pressure. Okay, therapeutic use, we use a loop diuretic for edema and drug of choice. This is bold, underline, that means is very important topic. Patients suffer from edema. Let me say this patient suffer from peripheral edema. We prescribe loop diuretic. Pulmonary edema, loop diuretic. Acute or chronic peripheral edema, loop diuretic. So edema could be due to the heart failure, renal failure, or hepatic failure or hepatic impairment. So if you have patients suffer from edema, the loop diuretic could be the choice, edema. And this edema could be in the pulmonary edema, could be peripheral edema, due to the heart failure or renal failure. This is number one. We already discussed that loop diuretic. We discussed that with you. Loop diuretic decrease. I'm going to say instead of decrease, because decrease in the blood, enhance elimination of calcium in the urine. That means loop diuretic will decrease calcium, blood calcium in the blood. So decrease calcium in the blood. In this case, we can prescribe it for patients who are from hypercalcemia. So any patients who are from hypercalcemia, loop diuretic may decrease hypercalcemia. But remember, we need to treat the causes of hypercalcemia, and we need to figure out and diagnose your patient. What is the cause of hypercalcemia, for example? Okay. Speaking about the cause of hypercalcemia, could be related to something called hyperparathyroidism. This is related to the four main small parts of parathyroid gland here in the neck. This is a thyroid gland. This is parathyroid gland, and this is responsible for secretion of PTH, parathyroid hormone, and this will lead to the hypercalcemia. So if the patient suffers from hypercalcemia due to the hyperparathyroidism, we can prescribe loop diuretic to decrease calcium in the blood and improve symptoms. But this is like symptomatic treatment. We need to treat the cause of hypercalcemia. Okay. Okay, moving to the next, we can prescribe this medication to treat patients with hyperkalemia. If the potassium level high in the blood, high blood potassium level, this medication could be used, because we know that not only calcium will be loop diuretic, they found also increased excretion of potassium in the urine. So what happened to the potassium in the blood? Will be decreased potassium in the blood. Okay, for this reason, we use it for patients suffer from hyperkalemia. Okay. What about loop diuretic adverse effect, side effect, or undesirable effect, unwanted effect? Patient may suffer from ototoxicity, acute hypovolemia, hyperuricemia, hyponatremia, hypocalcemia, uh, hypokalemia, potassium depletion, hypomagnesemia. And remember, we have the first three group of medication belong to the sulfa group. If the patient suffers from sulfa allergy, this medication is not allowed to prescribe to your patient. It's contraindicated. Not allowed to prescribe to patients suffer from to patient who has allergy to sulfa. Okay, moving to the adverse effect. For some important adverse effects to be addressed, ototoxicity. Ototoxicity. This medication may cause ototoxicity to the hearing, or could be caused like vertigo or like imbalance because affect the ear. Ototoxicity, toxic effect on the hearing system. The patient may suffer from damaging the hearing system. So what happened here? They said sometimes you can imagine the case here. The patients suffer from urinary infection, okay, and you prescribe medication to to the patient. Let me say 10 years old patient or child, and this child suffers from urinary tract infection. The physician prescribed gentamicin injection to this patient. Okay. Gentamicin cause ototoxicity. This is number one. Okay. So gentamicin cause ototoxicity for the child, and this ototoxicity could be irreversible. I will remove the 10 years old. I will say, okay, we have a 65 years old patient, and he is already on furosemide, and this patient come to the clinic suffer from urinary tract infection. His physician prescribed gentamicin injection, but he was not aware that furosemide cause ototoxicity and gentamicin cause ototoxicity. So the result will be, or could be, permanent toxicity damage, and the patient will suffer from deafness. The patient will become deaf. So what happened there? They said it's like contraindicated. We don't prefer to use furosemide, loop diuretic, with aminoglycoside. Okay, what is that link now? Because aminoglycoside, gentamicin belong to the aminoglycoside antibiotic. Okay, so gentamicin and loop diuretic is a contraindication to prescribe it together. Okay, ethacrinic acid may cause deafness alone. If you prescribe it without any maybe combination, may cause deafness. Ethacrinic acid more than other group of loop diuretic, other agent. More, that mean more than, I will put here more than, for example, furosemide or bumetanide. Okay, so the ototoxicity, very important topic to address. Ototoxicity could be irreversible sometimes. Hyperuricemia. Hyperuricemia mean increased level of uric acid in the blood. Okay, hyperuricemia. By competing with the uric acid, on the renal secretory system. Furosemide, ethacrinic acid limit the secretion of uric acid and causes exacerbation of gouty attacks. Okay, so we need to maybe again explain what happened when you prescribe furosemide, and furosemide will be eliminated through the kidney, through the proximal convoluted tubule, okay, through something called the active transport, or like active secretion. So when you talk about active secretion, you can imagine we have transport here, like a carrier. I will say this is a carrier here. This is a carrier. Okay, so we have furosemide. Okay, we have uric acid. And this is a blood here. Okay, this is the blood, and this is a BCT, and this is blood. Okay, and what we have here, this is a urine. This is a pharmacokinetic things. Okay, what happened here? Furosemide, I will make it like circular here with a, and then we have uric acid. Both of them will be eliminated through the same transporter, same active transport molecule. Okay, they tried to, this is a transporter. Okay, this is a BCT, the cells, and blood, urine. So in the blood we have the furosemide, and at the same time we have uric acid. We have uric acid in the blood, and you know that if the uric acid increase in the blood, the result will be hyperuricemia, increased level of uric acid in the blood. We don't need this one to happen. So what happened here? Uric acid will be eliminated through the process called active transport. We have transporter responsible for transport of uric acid from the blood to the urine, and eliminated through the urine. That's great. Okay, next, when you prescribe furosemide to your patient, so the furosemide will be eliminated with the same mechanism, with the same transporter, because this transporter not specific. This transporter demonstrate maybe less specificity for the transport molecules, so we'll be able to eliminate so many multiple molecules. So what we have here, you can imagine, I hope I will be able to, yes, that's great, okay, oops, okay, this is another one here. Okay, now the furosemide will be maybe occupied, the transporter occupied, and furosemide will be eliminated in the urine and through the BCT. Okay, furosemide will prevent active secretion of uric acid, not allow uric acid to be binding to the transport and eliminated. For this reason, uric acid will be increased in the blood. Increase uric acid in the blood. And the patient may suffer from hyperuricemia and risk of gouty attack. I think now that makes sense for us. Okay, so hyperuricemia and risk of gouty attack according to the competition on the secretory system and the proximal convoluted tubule. I refer students here to the lecture of pharmacokinetic first lecture in pharmacology. Another maybe important side effect, hypervolemia. Loop diuretic may result sharp drop in the blood volume. Patient may suffer from hypotension, shock, and cardiac arrhythmia. Okay, we have case study now, elderly patients with a cardiac history, experiencing difficult breathing difficulties, and diagnosed with the acute pulmonary edema. What treatment is recommended for this patient? Okay, number 1, acetazolamide. Number 2, chlorothiazide. Furosemide, spironolactone. Which one is correct? Acute pulmonary edema, emergency treatment, and we have accumulation of fluid in the lungs. Which one considered like strong diuretic? Which one considered like more potent? So if you choose furosemide, you are correct. Furosemide is a correct answer for acute pulmonary edema. Okay, we're done with the loop diuretic. We discuss the site of action. Okay, we discuss site of action. We discuss the mechanism of action. We discuss with you the clinical uses and adverse effect, or ADR. We discuss allergy to sulfa, for example. Okay, and then we have case study for a patient. And again, remind you, for the group of loop diuretic, we have furosemide, bumetanide, ethacrenic acid, torosomide. Okay. Okay, so moving to the next part about diuretic, we covered the osmotic diuretic. We talked about mannitol, glycerin, isosorbate. Then we moved to the loop diuretic. We covered loop diuretic and explain how this medication work, furosemide, bumetanide, ethacrenic acid, torosomide. The third group of diuretic will be thiazide, and thiazide will be very important and popular use. Again, you remember for loop diuretic, furosemide, bumetanide, this medication mainly used for patients suffer from, for example, for patients suffer from edema, for patients suffer from hypercalcemia, high level of calcium in the blood, for patients suffer from hyperkalemia. So this is a clinical use. The main clinical use for furosemide, loop diuretic, edema, hypercalcemia, hyperkalemia. Okay, what about the third group now? Is our topic, the third group, thiazide. We have hydrochlorothiazide, we have chlorothiazide, chlorthalidone, and dopamide, metalazone. This medication mainly used for hypertension. Please remember that. So this group of medication, thiazide, mainly used for hypertension, and I will start talking about this group of medication. Okay. Okay, so here you can see that we have a site of action for thiazide. As you can see, the site of action here. This group of medication, thiazide and thiazide-like diuretic, mainly affect the distal convoluted tubule, and the main mechanism of action, we need you to remember, this group of medication inhibit sodium chloride transporter. Okay, for this reason, thiazide inhibits sodium potassium transporter. Okay, that means this group of medication, thiazide and thiazide-like diuretic, will increase sodium and chloride in the urine. Okay, so what happened in the blood? The blood will be decreased. So I will say increase excretion. I will say it like this. We have urine here. We can say increase excretion of sodium and chloride in the urine. What happened to the sodium in the cells or in the blood? The result will be decreased level of sodium in the blood. Okay, what happened to the chlor? The same. Okay, that's great. So what happened there? We need to remember the mechanism of action of thiazide. Thiazide work on the distal convoluted tubules by inhibit sodium chloride co-transporter or sodium chloride transporter. Okay, what happened to the sodium in the blood? Decreased level of sodium, because this medication enhanced elimination of sodium in the urine. Okay, that's great. So next, what we have there, they try to remind us. So what happened here? We need to understand maybe a mechanism of action here, some mechanism of action. The sodium inside the cells, under the effect of thiazide, the sodium will be, do you agree with this one, will be decreased inside the cell as a consequences. Enhanced elimination in urine, that means this one not working properly. We don't have enough sodium in the cells. The cells will ask the blood, I need more sodium. So the cells need more sodium. Okay, but at the same time, you can see here we have exchanger. And this exchanger responsible for reabsorption of sodium and elimination of potassium. Take the potassium from the blood to the cells and try to bring sodium to the blood. Okay, but the cells now suffer from maybe suffer from decreased level of sodium. For this reason, this exchanger will be dysfunction, will stop functioning properly. What that mean? That means this cells does not allow sodium to go out, because this cells need sodium. Okay, what happened there? That means this exchanger will be start dysfunction. Okay, that means we have more sodium in the cells. When you have dysfunction, that means this cells try to not to bring potassium to the cells. Okay, this is number one. Number two. Okay, so what you can imagine here, and inside the cell we have decreased level of sodium inside the cells. This exchanger okay, when you have decreased sodium in the cells, let me go back a little bit, come back. When you have a decreased sodium in the cells, that means we have the number one here will be dysfunction. As I told you, we have another exchanger between calcium and sodium in the cells, sodium and calcium. When you have decreased level of sodium, this exchanger will be enhanced. And the reason why, because the cells will suffer from hyponatremia, decreased level of sodium inside the cells. For this reason, this exchanger will enhance. They will ask this maybe exchanger, I need more sodium. I will need to bring more sodium here. But this exchanger, in order to bring sodium to the cells, it needs to take calcium to the blood. This exchange. So bring sodium from the urine, from the blood to the cells, to the urine. But at the same time, we have exchange. They will bring calcium from the urine, bring calcium from the urine to the blood. That's great. What happened to the calcium in the blood? The calcium in the blood will be increased. So the situation here will be opposite. If you remember, if you go back to the loop diuretic. Okay. We need to remember this one again, the site of action, distal convoluted tubules. This medication inhibit sodium chloride sodium chloride transporter. Thiazide inhibits sodium chloride transporter in the distal convoluted tubule. This medication will enhance absorption of calcium in the urine and increase level of calcium in the blood. That's good. What happened to the calcium in the urine? Calcium in urine will be decreased. We don't have enough calcium in the urine. What about the blood? We have maybe enhanced absorption of the calcium to the blood. That's great. Thiazide loop diuretic, most widely used diuretic. Most widely used. Sodium excretion. This will help to excrete like 5% of sodium in the urine. For this reason, consider this group of medication considered like moderate effect. So we have strong diuretic, and here we are speaking about lube. Lube considered like strong diuretic. What about thiazide? Okay, moderate diuretic. Okay, now we're going to maybe see another one considered like weak diuretic. So we have strong, moderate, and weak diuretic. So this group of medication considered like moderate diuretic, 5% eliminate sodium in the urine, increase elimination of sodium, chloride, magnesium, water. We don't have calcium here. They said decrease excretion of calcium, enhance reabsorption of calcium to the blood. The blood will be, we are going to see increased level of calcium in the blood, and this is considered good sign. Increase calcium in the blood. We need calcium in the blood here. Okay. The next, this one here, compete with uric acid secretion and may cause you hyperuricemia, gouty attack. Okay, no need to explain this one because this one will be same mechanism as loop diuretic. We already discussed it in the previous slide. So when you prescribe thiazide, the patient will be at risk of hyperuricemia with the same mechanism of action. Also, they found thiazide increased synthesis of prostaglandin. I put it here. Thiazide increased secretion of prostaglandin and cause enhanced renal blood flow. So please remember that for this group of medication, thiazide. So the question now, give me a name of one of these medication. I will go back. Okay, this is the name here. We need you to remember the name. Okay, so we have hydrochlorothiazide, chlorothiazide, chlorthalidone, and dipamide metalazone. This medication work on the distal convoluted tubule. Okay, this medication molecular effect mechanism of action inhibit sodium chloride transporter. This medication decrease excretion of calcium in urine and increase level of calcium in the blood. Okay, most widely used. Okay, thiazide like diuretic, orally effective. Chlorothiazide could be available IV, and I tried to bring some picture for chlorothiazide. Is available like for injection. Chlorothiazide sodium, chlorthalidone, and dipamide metalazone. 3 medication considered like thiazide. Thiazide likes. Okay, 3 medication: chlorthalidone and dipamide metalazone. This is called thiazide like diuretic. This 3 group of medication contains sulfonamide group. Okay, that means if the patient suffers from allergy to sulfa medication, we don't recommend to use it because of history of sulfa. Chlorothiazide effective as oral medication, chlorothiazide, and chlorothiazide prescribed for heart failure, cirrhosis, and cirrhosis edema. So again, we can type here like hypertension. Please remember that. Heart failure, hypertension, and cirrhosis edema. Thiazide. Okay. Now we talk about calcium, or the slide here addressing the calcium, and this is very important. They found that thiazide decrease urinary calcium. We already covered that. Thiazide promote reabsorption of calcium. That's great. We need calcium in the blood. Okay, on the other hand, so this is thiazide here. This is the thiazide. On the other hand, loop diuretic, such as furosemide, okay, loop diuretic increase concentration of calcium in the urine. Okay. They said here, our topics for this slide, thiazide. They said, okay, thiazide, it's not this, thiazide, okay, useful in preventing calcium kidney stone. Thiazide, lower risk of osteoporotic fractures. Okay, does that make sense for us? Thiazide useful in the preventing calcium kidney stone. Yes, because thiazide decrease calcium in urine. Okay, does that make sense for us? Let me go to the whiteboard. Okay, so what we have here, you can imagine we have the container or the urine. Here we have the urine, and then we have calcium particles, all these calcium in the urine. Okay, now we are talking about, we prescribe thiazide. Okay, so what we have here, they said thiazide, we can look on this one. This is the effect of thiazide, and the same. Thiazide will decrease concentration of calcium in urine. This is urine here. Okay, decrease concentration of calcium in the urine, and therefore thiazide decrease formation of kidney stone, because we don't have saturated calcium in the urine. Okay, when you have kidney stone and the patient, for example, the patient has history of kidney stone plus heart failure, we can prescribe thiazide as drug of choice, because we have two main beneficial effects. Thiazide used for treatment of heart failure, thiazide reduce formation of kidney stone. So for this reason, thiazide could be beneficial choice for the patients who are from heart failure and stone, patients who are from hypertension and kidney stone, calcium kidney stone. Okay, the drug of choice will be thiazide. Okay, so thiazide decrease concentration of calcium in the urine. What about the other hand? So the other hand, I will put it in the green. We have furosemide. For furosemide, this is a urine here. They said furosemide increase elimination of calcium in urine. That means we are going to have, I will make it like, okay, like, yeah. A lot of calcium in the urine, hypercalciuria. So the calcium, the urine will be rich in a lot of calcium in the urine. Okay. Okay, so you can see now, if you compare, okay, three maybe group, furosemide, thiazide, normal. Here we have normal. Okay, thiazide, talking about urine, decrease calcium in the urine. Furosemide increase calcium in the urine. Okay, for this reason here, we can prescribe thiazide for patients from risk of formation kidney stone. On the other hand, furosemide, we don't prefer to use it in patients with calcium kidney stone, because the risk of formation, increased risk of formation of kidney stone, increase of calcium concentration in the urine. So you can see it here, increased risk of calcium concentration. I hope this makes sense. Okay, this number one, use thiazide. We explain why thiazide is useful in patient with calcium kidney stone. You know that we have decreased level of urine. That's good. We're going to remove this one. Move to the next one. We already familiar thiazide in increase level of calcium in the blood. So we can make it like this one here. Decrease calcium in the urine. This will lead to the increased level of calcium in the blood. Okay, that's good. When you have increased level of calcium in the blood, what happened to the bone? We're going to have more calcium in the bone. Okay, therefore they said, okay, this medication lower risk of osteoporosis because they're going to bring more calcium to the bone. Okay, so now we'll explain why thiazide is good for patients suffer from osteoporosis. We are not going to treat patient suffer from osteoporosis with thiazide. But let me say you have a 65 or 70 years old patient, and this patient has a history of osteoporosis plus heart failure or hypertension. So I prefer to prescribe thiazide to this patient because thiazide help to prevent maybe osteoporosis or increased risk of osteoporosis. Okay, I think now this makes sense here. Okay, therapeutic uses. This medication used for hypertension. This medication used for heart failure. Hypercalciuria. We talk about calcium, increased level of calcium. If the patient suffers from hypercalciuria in the urine. Okay, we discussed that. Nephrolithiasis, increased level of stones, kidney stone. Hypercalciuria, it's like repeated. We need to, okay, nephrolithiasis due to the idiopathic hypercalciuria. Nephrogenic diabetic insipidus. So we have maybe two mechanisms related to the heart. Then we have another local effect or like local disease, hypercalciuria, nephrolithiasis, and diabetes insipidus. Okay, for hypertension, thiazide considered best choice here in our topics. But when you talk about best choice, when you have hypertension, drug of choice. Okay, I will start with the ACE inhibitor. I will say CCB. Then we go to the thiazide. Okay, so number one, and this is number two. And the reason we choose thiazide because thiazide inexpensive, convenient to administer, and well tolerated. This one for heart failure. Then for hypertension, so number one indication or uses hypertension because this medication convenient to the patient, well tolerated, inexpensive. This medication used for heart failure, yes, but it's not first choice. We prefer to prescribe loop diuretic. So we can choose loop diuretic, but if the patient resists the loop diuretic and with not enough response, we can add thiazide. So the patient suffers from heart failure, but patient does not respond to the furosemide loop diuretic, we can add thiazide. If the patient resists, maybe demonstrate resistance towards loop diuretic. This is number two. Number three, hypercalciuria. Hypercalciuria mean increased level of calcium in the urine. Okay, the thiazide inhibit excretion of calcium in the urine, and this one considered like idiopathic hypercalciuria and calcium oxalate stone in the urinary tract. And we already covered this one in the previous slide on the whiteboard. Okay, again, hypertension, heart failure, hypercalciuria, nephrolithiasis, and nephrogenic diabetes insipidus. The last one will be covered in the endocrine pharmacology. Okay, side effect. The patient may suffer from hypokalemia in the blood, decreased level of potassium in the blood. Here, all these we talk about the blood. For example, here, this one represents the blood. Okay, we have hypokalemia, decreased level of potassium in the blood. Hyponatremia, sodium in the blood. Okay, I will take this one out. Hypovolemia, decreased level of blood volume. Hypercalcemia, hyperglycemia. So you can see all these reflect the blood. So talking about the blood, what happened here? Okay, I will type here blood. and try to understand what happened to these ions. Potassium, decreased level. What about sodium? Decrease, because this medication eliminate. What about blood volume? Hypervolemia. Okay, what about calcium? You tell me about this one. In the blood, what happened? Hypercalcemia, increased level of calcium. What about the glucose? Hyperglycemia. Okay, and the last one will be hypersensitivity due to the allergy and sulfur molecules. So if the patient suffers from allergy towards sulfonamide, we don't recommend to use thiazide. Some explanation for this medication here. Hypokalemia. This is most frequent seen adverse effect, especially if the patient taken digoxin, and this may predispose patient to the ventricular arrhythmias. Okay, number one. Number two, this is drug interaction. Thiazide, digitalis, or digoxin, increased risk of ventricular arrhythmias. Hyperuricemia, increased level of uric acid in the blood, and the uric acid will be deposit in the joints and cause gouty attack. Hyperuricemia, this is similar to the loop diuretic, the same ground, loop diuretic thiazide. Hypercalcemia, increased level of calcium in the blood due to the inhibit secretion of calcium, increased level of calcium in the blood. And we discussed the beneficial effect of these maybe action. Hyperuricemia, I think it's like this one repeated here, I'm not going to speak it. Hyperglycemia due to the impaired release of insulin in the blood. Okay, case study now. We have 55-year-old male patient with a history of kidney stone. Okay, necessitating a reduction in urinary calcium excretion, seeking the most effective diuretic therapy to optimize prevention of recurrent kidney stone in this patient. This patient suffers from hypercalciuria and kidney stone. Which diuretic offers the most potent reduction in urinary calcium excretion? We need to reduce urinary calcium excretion. We need to reduce the concentration of calcium in the urine. Which medication decreases calcium excretion? Okay. What about tyrosumide, hydrochlorothiazide, spironolactone, or trimetrin? If you choose hydrochlorothiazide, you are correct. Hydrochlorothiazide decreases excretion of calcium in urine. And for this reason, this will lead to the decreased formation of calcium kidney stone. Okay, so we already covered 3 groups of medication with you. The first one osmotic, the second one diuretic, the third one thiazide. We are going to maybe discuss the group number 4 from diuretic, will be potassium. Okay, potassium-sparing diuretic. Okay, for the talking about the group of medication here, again, so we cover with you the first group of medication, osmotic, diuretic, and then we discussed loop diuretic, and we went through the thiazide. We covered thiazide about heart failure, about cirrhosis, about hypertension, and we discussed the effect on calcium concentration in the urine and blood. And next group will be potassium-sparing diuretic. For potassium-sparing diuretic, we have less of medication. Number one, we have amiloride. Then we have triametrin. Next, we have eprinone. Then we have spironolactone. We have a new medication, phenrinone, in the market, Carindia, a new medication 2022, 2023, I think, approved in the clinical practice. So I will repeat it: amiloride, triametrin, eprinone, spironolactone, phenrinone. This group of medication belong to the potassium-sparing diuretic. This group of medication work on the collecting duct, collecting tubules. So we are going to cover this group of diuretic in the next coming slide. Okay, as a quick recap, we already covered three main diuretic groups. The first group was osmotic diuretic. The second one was loop diuretic. Then we moved to the thiazide. We covered thiazide, medication, hydrochlorothiazide, the chlorthalidone, and dopamide, and the site of action, the mechanism of action, which transport will be inhibited by this diuretic. Then group 4 will be potassium diuretic. Okay, as you can see here, we have the group. We are going to speak about that in details about the potassium-sparing diuretic. Okay, for the potassium-sparing diuretic, this group of medication work on the collecting tubule and duct, collecting tubule and collecting ducts. They try to tell us that sodium enter principal cells through the channels, rely on the sodium-potassium ATPase. This is pump sodium-potassium ATPase to be transported to the blood or into the blood. So the sodium will enter the cells. Then we have pumps bring the sodium to the blood. Okay, what happened there? They said we have hormones called aldosterone. So we have aldosterone hormone affect the collecting tubule and collecting duct. We know that aldosterone produced from which organ responsible for secretion or producing aldosterone? So if you said adrenal cortex, you are correct. Adrenal cortex will be responsible for secretion of aldosterone. Aldosterone site of action will be the collecting tubule and collecting duct. What is the main function of aldosterone? Will be increase sodium and water reabsorption. On the other hand, will be increased potassium excretion. So sodium and water will be reabsorbed, come back to the blood, and potassium will be enhanced in the urine. Okay, this is the main maybe agent, substance, endogenous agent. Aldosterone, we have it in our body, produced from the adrenal cortex, goes to the kidneys, enhance absorption of sodium and water, and increase excretion of potassium. That's great. This is the main action of aldosterone. We need to remember this action. Which of the following represent action of aldosterone? Increase sodium and water reabsorption, bring sodium and water from urine to the blood, and increase excretion of potassium in the urine. Okay, moving to the ADH. ADH stands for antidiuretic hormone and another name vasopressin. Antidiuretic hormone vasopressin. This group of this medication or this endogenous substances, this hormones, I will consider this one like hormone. This hormone, okay, promote reabsorption of water from the collecting tubules and ducts. So which hormones here mainly promote reabsorption of water in the collecting duct? ADH, vasopressin. Okay. This is a collecting duct and tubules. This is the normal collecting duct and tubules. As you can see here, in this slide, we have sodium channels, we have potassium channel, we have pump for sodium and potassium, ATPase pump. So we need students to be familiar with this component on the collecting duct and collecting tubules. Okay, in the collecting duct, we have sodium channels, we have potassium channels, and we have water channel. So we have three main targets. I will repeat it. We have sodium channels, potassium channels, water channels, and the collecting duct and collecting tubules. Okay, let us repeat this mechanism of action for aldosterone. As you can see here for the aldosterone, okay, enhance absorption of water, enhance absorption of sodium to the blood, and number 3 will be enhance excretion of potassium to the urine. So this is the main mechanism for aldosterone. Aldosterone brings sodium and water to the blood and eliminated of potassium to the urine. Okay, now we have the physiology, the first maybe image here, the cells, collecting duct, collecting tubule, the physiology. Moving to the pharmacology, as you can see here, we have a group of medication. Slide, we have a lot of information here. Okay, what we have there? They said we have maybe 3 group of medication in the slide. Very important group of medication: amiloride, triamethrin. 2 medication. This medication blocks sodium channel. That's it. What happened? Increased excretion of sodium in urine. Block sodium channel. The only one. Block sodium channel and increase sodium in the urine. Amiloride, triamethrin. Okay, done. What about next group? We have spironolactone, eplerenone, and Kerendia, Finrenone, spironolactone, eplerenone. This medication block aldosterone receptor. This medication block aldosterone receptor. So remember, if you go to the previous slide, when you block aldosterone receptor, when you block the aldosterone receptor, you block this one. You block this mechanism when you block aldosterone receptor. So the result will be, okay, when you block aldosterone receptor, the result will be, okay, the opposite action of aldosterone. The opposite action, okay, that we are going to speak about what happened: increased excretion of sodium and water in the blood, increased excretion in the urine, enhance excretion in the urine. Number 2, try to retain potassium. Keep the potassium. For this reason, we call this one potassium-sparing diuretic. So for this reason here, you can see the effect according to the main effect here. This medication tried to eliminate sodium and water in the urine, but at the same time, this medication will retain potassium in the blood. Okay, if you retain potassium in the blood, that means we have risk of hyperkalemia. Okay, this is a summary here. The group of medication: 1, 2, spironolactone and triamethrin. Okay, inhibit or decrease sodium and water reabsorption, inhibit water reabsorption, and inhibit urine excretion. This will lead to the increased potassium in the blood and may cause hyperkalemia. Okay. Kerendia is a new medication. It's considered like mineral corticoid receptor antagonist. Kerendia, with the brand name for the Finrenone or Finrenone. Okay, so we already covered what we have here. I will leave the vasopressin to the endocrine hormone later on. So what we have here, we cover two main groups. The first group will be amiloride and triametrine. The second group, spironolactone, eprinone, and phenrenone. Okay, the medication, this medication, we have the link here for this medication for potassium-sparing diuretic. This is considered like a non-steroidal mineralocorticoid receptor antagonist. Indicate for reduced risk of EGFR decline, end-stage renal disease. We prescribe to the patient. This medication found to decrease cardiac death and decrease myocardial infarction, decrease risk of hospitalization in patients with CKD and type 2 diabetes. So when the patient suffers from type 2 diabetes plus CKD, this medication will be the drug of choice. Okay, aldosterone antagonist. Here we have potassium sparing. We have two main group of medications: spironolactone, and then we have amiloride triametrine. Spironolactone, eprinone antagonize aldosterone receptor by inhibiting aldosterone activity. We already covered that. Eprinone is more selective than spironolactone. So spironolactone is considered like diuretic, but spironolactone not selective. Eprinone more selective. Eprinone has fewer endocrine effect. Eprinone has less occur of gynecomastia. Less. Please remember that. Eprinone causes less endocrine effect, less gynecomastia compared with the spironolactone. Amiloride triametrine, what is the difference? Okay, spironolactone, eprinone antagonize the L receptor. Okay, they said, wait a minute, amiloride triametrine, no, it's not related, are not related to the receptor here. Not related to the receptor. We don't have receptor here. This two group of medication will go to the channel, sodium channel, and block the channel, close the channel. This medication inhibits sodium channel directly, block transport of sodium channel, decrease the same, and prevent. So we have the same process. Okay, two group of medication here. We have spironolactone work as aldosterone antagonist. Then we have amiloride. Okay, then we have amiloride and triametrine. The question here, which of these medications work as aldosterone receptor antagonist? Spironolactone and eprinone. Which of these medication considered like potassium-sparing diuretic by direct inhibit of sodium channel? Amiloride, triametrine. Okay, the clinical use, therapeutic use of potassium-sparing diuretic, edema, especially if we talk about secondary hyperaldosteronism. Patients suffer from hepatic cirrhosis of nephrotic syndrome. The patient with these two types of disease, nephrotic and hepatic cirrhosis, the aldosterone level will be high in those patients. Hepatic cirrhosis, this is case study, or nephrotic syndrome, the patient will suffer from secondary hyperthyroidism, secondary hyperaldosteronism, and the result will be edema. For this reason, we prescribe spironolactone for this patient. So spironolactone could be used for treatment of edema in patient with a secondary hyperaldosteronism. Number one. Number two, hypokalemia. Because from the name, this medication retain potassium, spare the potassium, keep the potassium in the blood. If the patient suffers from hypokalemia, this is a drug of choice. If you put the patient on thiazide, loop diuretic, and the patient come to the clinic suffer from hypokalemia due to these medications, okay, we can add this group of medication to prevent hypokalemia. This medication, spironolactone, prescribed for patients with heart failure, especially talking about spironolactone, and prevent cardiac remodeling and decrease mortality. So we start about talking about mortality here. This medication could be prescribed for patients with resistance hypertension, and we cover this one in the lecture of hypertension. So I refer the student to the lecture of hypertension for more information. Spironolactone has anti-androgenic effect Therefore, it could be used for female patients suffering from polycystic ovary syndrome, which is associated with a high level of androgen. Spironolactone could be used for treatment of hirsutism. Increase body hair growth. So we have edema, hypokalemia, heart failure, resistance hypertension, polycystic ovary syndrome. Patient here, side effect, adverse effect, hyperkalemia, gynecomastia, especially with the spironolactone. So gynecomastia associated with the spironolactone due to the anti-androgenic effect. Spironolactone, but not epinephrine, may induce gynecomastia in 10% of male patient and could cause menstrual irregularity in female patient. Okay, two main side effects. We have another side effect, but this is the most popular, most important side effect. Okay, we're done with the potassium. So in this case, as you can see here in the slide, we already cover, we'll start with the first one. We already cover osmotic diuretic. We covered the osmotic diuretic, move to the loop diuretic, then we explained thiazide, and then we already finished the potassium-sparing diuretic. We discussed amiloride, epinephrine, spironolactone, and trimetrin. Okay, moving to the last group of medication. Moving to the last group of medication here, we are going to speak about diuretic that affect proximal convoluted tubules here. Okay, the proximal convoluted tubules exhibit apical membrane of sodium hydrogen exchange through the sodium hydrogen exchange, NHE3. This one here, sodium hydrogen exchange. So in the proximal convoluted tubules, we have exchanger. Okay, this exchanger will bring sodium to the blood, and in turn of removing hydrogen from the blood, removing proton from the blood. Okay, we have exchanger in the apical membrane here. Okay, so what happened there? When we bring hydrogen to the blood, hydrogen will be combined with the bicarbonate to form carbonic acid. The carbonic acid will be dissociated to the water and carbon dioxide under the effect of enzyme called carbonic anhydrase. Okay, and the carbonic anhydrase is responsible for catabolism of carbonic acid to the water and CO2. Okay, in the basolateral membrane, this is the basolateral membrane here, this one here, basolateral membrane. This is the apical membrane. So we have apical membrane, we have basolateral membrane. And the basolateral membrane, as you can see here, they said we have pump. In the basolateral membrane, we have pump. Okay, yes, correct. And this pump responsible for bring everything to the normal, to the balance, bring sodium to the blood, and bring potassium to the urine or to the cells. Okay, we have the basolateral membrane contains sodium, potassium, ATPase to ensure a normal intercellular sodium and potassium level. Bring the balance to the cells and the blood. That pump, the function of pump, sodium, potassium, ATPase. Okay, so what we have here, we have rapid equilibration result in similar solute concentration in the interstitial fluid and blood. So the main function of this process here, the main function is to be sure we maintain the balance between the blood and urine balance in the solutes or in the electrolytes and water. We need the balance. We have exchanger and we have pump. Okay, this is very important one. Okay, then they said what we have here, our target will be enzyme called carbonic anhydrase, CA, carbonic anhydrase. So carbonic anhydrase is enzyme available in the proximal convoluted tubules, and this enzyme responsible for, you can see it here, this is enzyme responsible for catabolism of carbonic acid to the CO2 and water. Okay, cleaves the bicarbonate. Okay, it's the carbonic anhydrase enzyme available in two places, available in the brush border. This is a carbonic anhydrase in the brush border, and available in the luminal membrane, inside the cells, in the cells. So two places for carbonic anhydrase. Carbonic anhydrase is available in the brush border. This is the brush border, and available in the cells. Okay, we can find the carbonic anhydrase in other location. I need someone to tell me where is the other location for the carbonic anhydrase. Do you have it in other location, carbonic anhydrase? Can you help me remember the other location for carbonic anhydrase? I will keep it for you, and then we can discuss it later on. Okay. Additionally, you can see here we have another transporter. We call this transporter like SGLT, sodium glucose transporter, and this transporter is responsible for reabsorption of sodium and the glucose. And the new medication now for diabetes work on this transporter, inhibit this transporter for type 2 diabetes. Okay. Now we have this is the physiology of proximal convoluted tubules. So here we need to remember, remind you, we have this enzyme called carbonic anhydrase inhibitor, and this carbonic anhydrase, and this enzyme responsible for catabolism of bicarbonate to the water and CO2. Okay, moving to the slide. So we have a list of medication. If you remember, this is the main medication, acetazolamide, but we have brinzolamide, dorzolamide. So the main medication here, acetazolamide, the prototype. Then we have dorzolamide, brinzolamide. Acetazolamide, we have the minus here, that mean inhibit. Acetazolamide inhibit the enzyme, carbonic anhydrase. The result will be inhibit maybe the formation of CO2 and water, accumulation of bicarbonate, accumulation in the urine. Okay, that's good. In the cells, we have decreased bicarbonate. This will be happen in the blood, decreased bicarbonate. We are on the same page, is that correct? So this medication, acetazolamide, inhibit carbonic anhydrase. That will lead to the prevention of catabolism of bicarbonate to the hydrogen to the water and CO2. Okay, in the lumen and in the blood and the cells will be decreased formation of bicarbonate and decreased levels of bicarbonate in the blood. Okay, the situation here, as you can see, we have increased excretion of bicarbonate in the urine. We have 3 arrow here with the 3 arrow decrease. We have 1 arrow for the sodium. For this reason here, when they said they pull only 5% of sodium will be in the urine, they said this medication considered like mild diuresis. So now I would like you to remind you with the classification. We have strong diuretic, we have moderate diuretic, then we have mild diuretic. Okay, can you give me a name for strong diuretic? If you said loop diuretic, you are correct. For moderate, if you said thiazide, you are correct. For mild, okay, what we have here, I would say acetazolamide. And if you said carbonic anhydrase inhibitor, you are correct. So for the mild, this one responsible for 5% only for excretion of sodium. This medication causes rapid rise in the urinary bicarbonate. Urinary bicarbonate will be increased. So we have increased urine carbonate. The result will be urinary alkalosis. You agree with this one? Urinary alkalosis. So when you prescribe acetazolamide, the result will be urinary alkalosis because we have increased level of bicarbonate in the urine. Increased level of bicarbonate in the urine. Okay, what happened for the bicarbonate in the blood? Decreased level of bicarbonate in the blood. We have increased bicarbonate in the urine, and the result will be urinary alkalosis. That's great. What happened to the blood? Metabolic acidosis. We don't have enough bicarbonate. We have less bicarbonate. The result will be metabolic acidosis. Okay, this medication causes like mild diuresis, decreased ability to exchange sodium for hydrogen, retain bicarbonate in the urine, elevation urinary pH, alkalosis here. This medication, acetazolamide, mainly used to alkaline the urine, if we need to alkaline the urine, urinary alkalization. This medication used if the patient suffers from urinary alkalosis, according to the effect. This medication used for patients suffer from altitude sickness. And this medication used for treatment of glaucoma. I know you are now remembering the glaucoma treatment. Acetazolamide used for glaucoma because we have carbonic anhydrase in the eye, and acetazolamide inhibit this enzyme, and this will lead to the decreased formation of aqueous humor in the eye. Okay. Therapeutic uses: treatment of chronic glaucoma. We already covered that. Decreased production of aqueous humor and reduce intraocular pressure. This will be prescribed orally. We talk about acetazolamide orally, tablet or capsule. We have topical like eye drops. We have dorzolamide, brinzolamide, and this medication applied topically on the eye with no side effect or systemic effect. So when you prescribe something like topical on the eye or on the skin, we are going to have less side effect, less systemic side effect. Okay, any side maybe altitude sickness. This medication used for prophylaxis of altitude sickness. Acetazolamide prevent weakness, breathlessness, dizziness, nausea, and cerebral edema, as well as pulmonary edema. Okay. For this reason, we prescribe it for the people who climb the mountain to prevent the cerebral and pulmonary edema. Okay, I like what we have here at the end, urinary alkalization. This one belongs to the chemistry and biochemistry. We need to be familiar what happened with the chemistry and biochemistry in simple biochemistry. They said this medication increased solubility of cysteine and or uric acid to prevent stone. Wow. So we have two types of stones now. We have calcium stones, and then we have kidney. We have cysteine and uric acid stone. So we have two types of stone. We have kidney stone related to the calcium kidney stone, and you have uric acid kidney stone. Okay. This is chemistry, as I mentioned. If this kidney stone related to the calcium concentration, increased calcium concentration and the kidney stone, calcium kidney stone, Okay, what is the main, maybe think about which is the appropriate diuretic for this patient. Okay, I will say, I will go with the thiazide. Good option. Try to avoid what? Loop diuretic. Okay, does that make sense? Because loop diuretic increase concentration of calcium. Okay, what about uric acid kidney stone? Uric acid, from the name acid, so the urine is acidic, so we try to alkaline the urine. Which diuretic mainly alkaline the urine? Which diuretic cause urine alkalosis? If you said acetazolamide, you are correct. Now we are able to manipulate kidney stone. If the patient suffers from calcium kidney stone, which of these medication will be appropriate to use? Thiazide. We need to avoid loop diuretic. If the patient suffers from uric acid or cystine stones, we go with the acetazolamide, because acetazolamide alkaline the urine. Okay. So your urinary alkalization is very important topic for us. Side effect, some patients may suffer from metabolic acidosis, calcium carbonate renal stone formation. This is as a side effect, calcium stones. Contraindication, we don't prescribe it for patients from cirrhosis or hepatic encephalopathy. The patient in this liver disease and cirrhosis, hepatic encephalopathy, here the patient suffer from risk of metabolic acidosis. There is a risk of metabolic acidosis. Okay, our medication cause metabolic acidosis. For this reason, we don't prefer to use it in patients with the cirrhosis. Okay, the question now, I will say, for example, you have patients suffer from cirrhosis plus edema. The question, which medication not allowed to prescribe to your patient? Acetazolamide, not allowed. Okay, that's great. Which medication we need to prescribe to your patient and consider like drug of choice? If you review the slide and go back again, thiazide will be the drug of choice. Okay. I hope this makes sense for you. Okay, we have some medications here. We have the acetazolamide, available like capsule or like tablet. Then they said, wait a minute, we have another group of medication, dorzolamide, iode solution, drops of ophthalmic solution for patients suffer from glaucoma. So we use it for patients with risk of glaucoma or treatment of glaucoma. Okay, 59-year-old patient in the intensive care unit. He has a metabolic alkalosis. Which of the drug will treat this patient condition? Amiloride, okay, hydrochlorothiazide, mannitol, and acetazolamide. So the patient suffers from metabolic alkalosis and he is intensive care. So which medication used to treat the metabolic alkalosis? Acetazolamide. Okay. Okay, another case study here, a group of college students planning to a mountain climbing trip to the Andes. Which is most appropriate for them to take to prevent altitude sickness? Prevention of altitude sickness. Okay, shall we say thiazide, anticholinergic, atropine, carbonic anhydrase, loop diuretic? So what do you think? If you choose a carbonic anhydrase inhibitor, you are correct. Acetazolamide for prevention of altitude sickness. Okay, next case. An alcoholic male has developed hepatic cirrhosis. To control ascites, which mean accumulation of fluid in the abdomen, to control ascites and edema, which should be prescribed to this patient? Acetazolamide, chlorthalidone, furosemide, or spironolactone. If you choose acetazolamide, you are correct. But if you choose a what do you think? If you choose acetazolamide, you are correct? Can you convince me this is correct choice? I believe it's not correct choice. Because with the hepatic cirrhosis, the patient here suffers from metabolic acidosis. And acetazolamide cause metabolic acidosis is contraindication. It's not allowed to prescribe. Furosemide, no, it's not first choice. Spironolactone, no effect. Chlorthalidone belong to the hydrochlorothiazide. Okay, chlorthalidone will be for patients suffering from hepatic cirrhosis. Which diuretic has been shown to improve blood pressure in patients with resistant hypertension or those already treated with a 3 blood pressure medication, including thiazide, loop diuretic? So the patient already on 3 medication, but no control on blood pressure. So we need to add something to control. Okay, endopamide, furosemide, mannitol, or spironolactone. Which one may be best prescribed for resistance hypertension? If you go with the spironolactone, you are correct. So the spironolactone will be the correct answer here. Okay, we have some medication name here. For example, Eprinone. We have triametrin with the brand name, spironolactone, thiazide, amiloride, and then we have bumetanide, torsemide, we have hydrochlorothiazide, chlorthalidone. Okay, next question. Which of the following diuretic is contraindicated in patient with hyperkalemia? I like this question. Which medication, which diuretic contraindicated in patients with the hyperkalemia? Increased level of potassium in the blood. Okay, if the patient suffers from hyperkalemia, which medication is not allowed to prescribe? We don't need to prescribe this medication. It's like contraindicated. Acetazolamide, hydrochlorothiazide, ethacrenic acid, or Eprinone. Take your time, think about this question. Hyperkalemia. We need to, it's not allowed to prescribe. Which of this medication may cause hyperkalemia? This is another way of us to ask a question. Which of these diuretic may cause hyperkalemia? Okay, let me discuss that. Ethacrenic acid decrease potassium in the blood. For this reason, this is wrong. Chlorthalidone decrease potassium in the blood. This is not correct. Not correct also. Okay, acetazolamide. This medication mainly work on the BCT by inhibit carbonic anhydrase, and the main effect will be the bicarbonic or carbonic acid. No direct relationship with the potassium. Not direct, but Eprinone. This medication, if you remember, considered like potassium-sparing diuretic, retain potassium in the blood. For this reason, the potassium will be high, and this one will be the correct answer. I hope this makes sense for you. I will stop here for diuretic. I'm not going to discuss antidiuretic hormones because this one consider hormones, and this one will belong to the endocrine pharmacology. I hope this lecture was beneficial for you, and this will be applied to your courses, your syllabus, and your information for short, long-term applications. I hope you will maybe remember and understand and apply the information from our lecture today, and wish you the best and good luck, everyone.